Good morning, everyone, and thank you for joining this morning session of the 2022 North Country Leadership Summit, Optimizing Healthcare, Community Collaboration, and Workforce Resiliency. My name is Nancy Del Mastro, Telehealth Project Manager at Adirondack Health Institute. We want to give a quick shout out and thank you to all of our sponsors for this year's summit. Without the continued support from all of our sponsors, we would not have such a successful event. So thank you all again. So some quick housekeeping items before turning it over to Dr. Rouhana. Please place any questions you have during the presentation in the chat box, and we will ensure that those are addressed during the Q&A portion of the session. All attendees, please remain muted with your video off for the entirety of the presentation to reduce any distractions. And finally, all presentations are being recorded and they will be archived on the North Country Leadership Summit website for reference and review after the conference. And with that, I would like to introduce this morning's presenter, Dr. Nicole Romana from Binghamton University, presenting on addressing challenges related to recruitment and retention of rural nursing workforce.
Thank you very much, Nancy. We're all set? Everybody can see everything?
Yes, looks great.
Thank you. So thank you very much for the planning committee and for everybody attending this morning. I'm very excited to be able to tell our story of here at Binghamton University of what we're doing to combat the nursing workforce problem in rural New York State and Pennsylvania. So this morning I'll be presenting some challenges that we've experienced relating to recruitment and retention of rural nursing workforce. I'll go through our presentation and highlight some areas, and then I'll open it up for discussion afterwards. This morning, I would like to share that we should be able, at the end of this, to describe the challenges of caring for rural individuals in rural healthcare systems, look at social determinants of health and rural theory and how these influence people's ability to really accept healthcare delivery, and then understand some solutions that we've created to teach telehealth skills in higher education to really help prepare the workforce to be ready for that. I would like to acknowledge that this work has been funded by the HRSA Anew Award. This was a $2.8 million funding opportunity to develop a rural nursing workforce, promote telehealth in rural areas, and support our preceptors. So just a quick discussion of why does rural matter? We know that rural can look different in many different areas, both internationally and domestically. We know that Australia is way ahead of us in terms of actually looking at that rural research and how we can retain workforce in those areas and how we can address some of the more disadvantaged health situations that occur in those areas. But you can see this is in the first picture here is in central New York.
Dr. Rouhana?
Yes.
I'm sorry to interrupt. We still see your title slide.
Oh, sorry about that. Is it moving now?
Yes, now we see the objectives.
Great. So I'll go back to why rural matters. The first picture right here is a picture of what we see in central New York. Off to the right is a rural scene where I just presented out in Las Vegas, and this is a rural icon for them. And then this is New Mexico. So, there's many different visions of what rural is. But when people initially think about rural, they think about a farming, agriculture area. And we know that in rural areas, especially in New York State, that may not be the case. So first, let's take a look at the complexity of place. Currently, 45 million Americans live in rural areas of the country. Only 9% of physicians and 11% of dentists actually practice in rural America. Rural youth are more than twice as likely to commit suicide, and this number is probably even higher now since the pandemic, which has really increased social isolation and the influence of social media. So that's become a huge issue, coupled with the problem of not being able to secure mental health workforce in these rural areas. 70% of all hospital closures in 2018 impacted rural areas, and the majority of these are critical access hospitals, which we know are critical to rural populations. And it can take an average American 34 minutes to access rural health care. So a rural individual doesn't really look at that both in time or distance. To them, it becomes a normal socio-demographic factor that they just realize they may have to travel for health care, and it's a given. So there's some U.S. population changes that are impacting rural health care. We know that the U.S. population growth has slowed over the last 2 decades. And in this decade alone so far, it's the lowest decade where we are seeing an increase in birth rates. So for a variety of reasons, people of childbearing ages have elected not to start families. Some of that is due to global warming. Some of that is due to people's concerns about overpopulation, and some of it is related to financial constraints, where it just may be too expensive for somebody to expand their family when they already have to live on 2 incomes. So these rural areas have seen a slight decline. The urban areas have, of course, seen a decrease of 8%. So what that has meant is as the rural population goes down, it's left 5.7% more rural poverty in those counties than the urban counties. So what we're seeing is our rural counties becoming poorer, which then contributes to more chronic disease. So it really has a lot of healthcare implications. I'd like to talk just a minute about isolation and distance, because this helps us understand why people seek health behaviors or health care. The average rural dweller, like I said earlier, lives 20 miles from emergency services and maybe 50 miles from routine care, but they don't feel isolated. So they tend not to talk about isolation, but that's figured into their calculation of their work, of where they live and where they work. So although they may not feel isolated, to us living in a suburban area or a rural area, we would call that isolated. They just look at it in terms of distance. So it's not always considered negative. We also know that there's complexities of rural people. So nationally, we know that rural people tend to be less likely to be insured. If there is government capabilities for healthcare, they may be a little bit more suspicious of that and may not enroll in those services. Therefore, they're less likely to participate in routine screening exams for a variety of reasons. Some of them may be work, some of them may be time, some of them may be inability to access childcare, but they really just don't have that in their framework of, I need to get an annual physical exam every year, or I need to get an annual mammogram every year. They will, however, make sure that their kids get those rural visits or those annual visits more than they will make sure themselves they get those annual screening exams. We've already talked about the fact that rural people oftentimes live in increased poverty, and that's due to lack of education, lack of employment advancement. We see in rural settings that many times there's 1 or 2 primary employers in the area, and that can be a factory, industrial opportunities, or education, or many times a healthcare organization like a hospital or a clinic that becomes the primary employer of that area. And if the people don't have the skills to meet that facility, they might not have the opportunities. Decreased education. We know that people living in rural areas are less likely to finish their high school education and might not have higher education, not because they don't seek it, but it may be more difficult to actually get out of the community, or they may have to travel to an educational institution. So that can become an issue. Now, distance education has done a lot to improve that. So a lot of higher educations are bringing distance education programs and formatting into education. So that opens up the doors, particularly for some women in terms of healthcare professions. We know that in rural situations, people are more likely to use tobacco. So not only smoking, but also using oral tobacco. And we know lately that there's been an increase of vaping, which has the same health consequences as to oral tobacco and inhaling tobacco. So that contributes to some complexities. We also know that there's an increased risk of head and neck cancers, particularly among young adults or adolescent males. And the reason for that we're seeing is because A, they start using tobacco products in whatever form earlier than females. B, there tends to be more alcohol use. And C, there tends to be less dental care. So this contributes to more head and neck cancers. A lot of these are related to HPV. And then we see an earlier sexual debut. So part of this may be, again, this is complex, but part of it may be related to the social norms. So if it's a rural, underserved community, a young woman getting pregnant as an early young adult may be the social norm for that family or that community. So a grandmother may be in their 30s and her daughter may be in her teens and is having a baby, and it's socially acceptable. So we see some earlier sexual debut, and that in turn can lead into, some unprotected intercourse, perhaps unwanted pregnancies, and some more complications of somebody actually having a pregnancy as a young adolescent. Also, late entry to prenatal care if there's a lack of antenatal providers. So then as we look a little further, we also see that there's complexities of the rural healthcare systems. And I feel like I'm preaching to the choir here because you are already experiencing and well-versed in what these complexities may look like. We know that rural healthcare providers may already be stretched very thin. They may see on average more episodic visits than preventive care annual well visits. During that episodic visit, for any of you here that are healthcare providers, you know that you will probably have a 15 to 20 minute window of opportunity to take care of that episodic event, but also scan that chart to see when was the last mammogram, when was the last antenatal care, has there been any lipid screening done, has there been any diabetes screening done. So from a care standpoint, we know that our providers are stretched really thin. And although they want to be able to offer these services, it's hard. So even if they say, okay, you're here for sinusitis, but you really need that annual visit, we need to see you back, go ahead and make that visit. We've done our share as a healthcare provider, but now it's up to that rural individual to actually make the appointment, keep the appointment, find the transportation in, maybe secure child care, and make sure that they may be able to get time off of work to actually carry through with those preventive screenings. You also know about the limited accessibility of healthcare. So we experience a decreased number of providers in healthcare organizations and decreased resources and facilities. I think that we've done a great job in networking and having rural satellite clinics that are available that tend to meet some of the community's needs, but that may not always be possible. There's a greater distance between care sites. So you may have a home base of a multi-specialty center with lots of little satellite clinics surrounding that, but that can still mean a greater distance based on what travel is, based on road conditions, and based on weather patterns and somebody's ability to actually access the healthcare. I think the biggest impact factor, which we're here to talk about today, is recruitment and retention. The average healthcare organization spends approximately $50,000 per one recruitment attempt to get a healthcare provider in their organization long term. We tend to look for individuals who have training for rural health, who are interested in creating roots in a rural healthcare system, and want to stay there. And therein lies the problem. When we identify urban healthcare providers that come into a rural setting to work, the average time that they stay there is 2 to 3 years. And the number one reason why a rural provider may not stay long-term in an area is because their partner may not like living there. So if their partner and their family is not happy, they get pressure to leave. We also know that education opportunities for their children may be an issue, so their spouse or partner may want to leave because of that. And in average, it really takes 3 to 5 years to build up a patient panel. So that's a problem, because when we see this revolving door of providers in and out of a system, rural people may lose confidence in that system because they just get the opportunity to develop a relationship with a provider, and then that provider has left. So this recruitment and retention really is an important factor we're going to talk about today. Then we have the issue of less public transportation for people to access your services. I think that we've done a good job of that in central New York with the Rural Health Network, and getting some pre-scheduled transportation out to people. So that is an area that's improving, but still may be an issue. Next, I'd like to talk about key concepts of rural theory. And this is important because this is what Decker does really well. Most of the research in our Doctor of Nursing Practice program and our PhD program has looked at rural theory and how that impacts health behaviors and health outcomes in New York State. These are 6 concepts that rural individuals tend to be impacted by. Their ability to think about what work belief means to them in terms of their health belief, how they perceive isolation and distance. Rural individuals are highly self-reliant, and this goes back to our Jeffersonian attitudes when we first were laying down roots as new immigrants. We are self-reliant. We left England to become self-reliant, and we wanted to make sure that we would never again be reliant on other people. There's a lack of anonymity in a rural community. So this is both from a rural individual perspective and also from the healthcare provider, where they tend to really lack, they lack some privacy, they lack some anonymity. And it's very easy for somebody to feel like everybody knows their own business. So maybe they don't want to go access women's health services if they know that that's going to be the talk of the town later on that day. There's also the influence of outsider versus insider. So as people are insiders that have grown up and lived in that community and are the mainstay of that community, they may be less likely to accept outsiders, and it might take them more of a while to become used to them. Then we have old timer and newcomer. So old timers are established people in the community that offer skills, they offer advice, they offer communication, and they may be reluctant to accept newcomers. So when we think about a rural person's belief about work, it's viewed very differently from an urban population. In the world, they feel that they are healthy if they have the ability to fulfill their daily functions in their job. So their health definition is, I can do my job. I'm able to go to work every day, whether that be farming, whether that be logging, whether that be factory work. Health needs are secondary to work needs. So they may be less likely to take time off of work to go to the doctors, or they will put off seeking health care if they have to work. And many times by the time they do seek health care, it's much later in the game. And maybe if it's a chronic disease, there's been more consequences because of that chronic disease. They also will, once they can no longer tolerate the pain, that's when they will seek health care. So only when they can no longer work because of an injury or if that impacts their ability, then they're going to go seek health care. But again, we saw that in rural Appalachia, this became a huge issue, why the opioid crisis really was marketed to rural Appalachia. They knew that these individuals would go to work no matter what. So opioids were sold to them as being non-addictive, but it would allow you to continue to go to work. And we know the rest of the story from there. So when we look at self-reliance, rural individuals strive for their independence. They have a very strong desire to take care of themselves and their families. We want to take care of each other. We don't rely on others for that help. This obviously impacts when and how they're going to seek healthcare servers. So they'll tend to rely more likely on those informal networks within their community as healthcare. So you can all imagine, or perhaps you've all experienced, the lack of anonymity in a community. This is the hallmark of small town living. You will have limited availability to have a private life. Some healthcare providers really look at this as either a benefit or a distraction. So as a benefit, healthcare providers become part of the community. They may see a patient in a school system, in a church or a worshiping system, in a social setting, and also as their healthcare behavior. So they're going to see that individual through many different lenses. And some rural providers love being that person that the rural population can call doc. They're the person on the corner that everybody goes to. Some people like that, others do not. It also really impinges on your privacy. So if you are the healthcare provider and you are out in the community and people come up to you frequently asking you for feedback, can you take a look at this rash? Or I want to tell you about my husband. Some people don't like that. So it can be viewed as a benefit. It can also be viewed as a risk. So providers get to know their patients on many different perspectives. That contributes to a little bit of role diffusion if you are a healthcare provider, particularly if you are enmeshed in that community. So when we look at outsider and insiders, old timers versus newcomers, this is a construct of how rural dwellers organize their view of their social development. So from a social demographic lens, they know who the insiders are, they are considered trustworthy, and maybe outsiders aren't considered as trustworthy. But there's a big interaction between these insiders' ability to connect with the outsiders or the newcomers, and they tend to be the gatekeepers of those rural organizations or those rural communities, so that as the insiders establish relationship with the outsiders, they can bring more information in. This tends to guide interactions and relationships among people. It takes on average 10 years to become an insider, about 20 years to get rid of that newcomer definition. As I said, they might be resistant to services from outside agencies unless an insider participates in those outside agencies. Then they're going to say, okay, my peers and my family access this service, so I might be a little bit more likely to access that. Insiders prefer healthcare from informal rather than formal settings. So if family and relatives participate in healthcare behaviors, they're going to be less likely to also participate in those behaviors. So we see this a lot with vaccines. My other area of research is vaccines, and we know that if family, friends, and relatives vaccinate their children, then parents are going to be much more likely to vaccinate their children also. So having these people involved in healthcare systems can otherwise impact people's ability to access healthcare. We also know that why I'm here today is to talk about the complexities of the rural nursing workforce. So the areas that I target right here are the North Country, which a lot of us are from today, and then this Catskill area. When we look at the regional distribution nurse practitioners in New York State, we see the most nurse practitioners here in the North Central and then the New York City region. So in the Finger Lakes region, there's about 107 nurse practitioners per 100,000 people. And in the New York Central region, it's 104. So we've got a pretty good presentation or access to healthcare through advanced practice nurses right here. Hudson Valley and North Country is the lowest. So on average, 50 advanced practice nurses per 100,000 people per county here. Rural nurses are less likely than urban nurses to report that they have enough education in their nursing background to care for rural people. So we know that nursing education is national. There's national guidelines, and that's what they're taught, but it doesn't always prepare them for the complexities of maybe working in a critical access hospital. Nurses in rural practice are more likely to report that they've got that inadequate training, and it's really a barrier for them to be able to do their job. So this leads us to how do we look at and create solutions for preparing our nursing workforce. Here at Binghamton University, we decided to grow our own. So using funds with that workforce grant that I spoke about early in the presentation, over the last 4 years, we have targeted rural communities and identified registered nurses who are interested in becoming nurse practitioners. This way, they have roots in their rural county. They're already established healthcare providers or nurses in that area, and they're going to want to stay in that area. So it's going to really reduce the cost of recruitment and retainment. One thing that I'm super excited about here is in this population right here, in this cohort alone, we had a 25% diversity rate, which spontaneously happened. And of course, we're always looking for diverse students, but one would think in a rural community, you wouldn't have access to that. This tells me that our rural counties may be becoming less homogeneous and more diverse. So we're interested in creating that workforce that's going to be able to serve some of our constituents. So the goals of the grant I'm speaking of today was to support advanced practice education in rural counties of New York, prepare family nurse practitioners and adult gerontology nurse practitioners to become experts in caring for rural and medically underserved counties, and be prepared at using telehealth. So when they graduate, they can step right into a practice that actually has telehealth set up. We also support our preceptors. So for those of you who may not be aware, clinical preceptors are qualified nurse preceptors already in a healthcare organization that oversees 660 hours of our students' direct patient care. So we send students out to these clinical agencies and they practice under the preceptors who's going to help them develop the clinical skills they need. Each preceptor receives an Air iPad Pro, and they are invited to an annual Preceptor Appreciation Day here on campus or virtual, where we provide them with 8 hours of continuing education, which is directly related to pharmacology. And then lastly, number 4, not number 3, we have funds to implement telehealth and telehealth education. I have one really one exciting story here. We have one graduate of our program who, when she graduated and became an alumni, her father was a primary care provider who was ready to retire. He sold his practice to his daughter. He served as a consultant down in Susquehanna, Pennsylvania. She purchased his practice, hired her father, who was a general practitioner, to become a consultant, and we provided her with telehealth equipment. Within the first year, COVID hit, so we provided her with more telehealth equipment, and during COVID, she was able to convert 80% of her primary care visits using telehealth. She has now hired another alumni of our program who's a psychiatric nurse practitioner. So she's able to integrate primary care or mental health services into her rural clinic. So she's kind of like the gold star of what we want to do here. There's multiple calls from our education accreditors to incorporate telehealth competencies. So we know the American Medical Association has a consensus on telehealth skills, which we look at. The National Organization of Nurse Practitioner Faculties, otherwise known as NOM, has a position statement on telehealth and has educational requirements, which we must teach. There's the American Association Colleges of Nursing. They have their own essentials, and they have essentials on telehealth. The Institute of Medicine report also most recently talked about the ability to graduate students with informatics skills and telehealth skills. And then, there's additional calls for telehealth education across other allied health professions that we have to be aware of. Now, a lot of these calls for telehealth competencies were in place pre-pandemic, but people probably really weren't that aware of them or didn't address them. But one of the advantages of the pandemic is it brought those into the forefront so that we not only knew they were out there, but we had to teach them. So in our nurse practitioner curriculum for these students that we're funding, they have to take these courses. So one is the rural imperative, and it's the theoretical frameworks of rural nursing that I briefly went over for you in some of the other previous slides. So we want those students to know this is why when you are practicing in a rural area, somebody may access healthcare late, or they may be reluctant to access healthcare. You have to know the patterns of people's attitudes and behaviors about rural health in order to be able to care for them. We also give them another course on health disparities across populations. So how does rural health impact geriatrics? How does it impact pediatrics? How does it impact maternal and fetal health? Those are things that they have to be prepared for, particularly if they're in those critical access hospitals where they have to be experts at a lot of things, but maybe a specialist in nothing. And then they have their own telehealth encounters in rural practice, where they have a three credit bearing course, and they actually practice in telehealth. So these are some of our students. This is Dr. Ann Franzek, and she heads up our rural telehealth simulation center, where our students actually practice giving some telehealth with some of our rural partners. To be eligible, our students have to be registered nurses in New York or Pennsylvania with an unencumbered nursing license. They must be accepted into our program, either our FMP or adult geri master's program. We also have a health nurse practitioner program and a psychiatric nurse practitioner program. For right now, we are only funding FMP or adult geri. We are getting ready to submit our next round of application for funding, and I'm strongly considering funding those psychiatric nurse practitioners in our next grant because they're really critical to primary care services in rural America. The students have to reside in a rural area with a RUC or RUCA code of over 4, and I'll talk about that in a minute. They have to be willing to complete the program full time. This becomes a little bit of an issue because a lot of our students have to work full time, but we give them a stipend because we don't want them to work full time, but we also don't want them to be part-time. We want them to have a rural immersive experience in their education. They must be willing to complete all clinical hours in a rural setting. So what we do is we match up the student in a healthcare organization that's in their county. That reduces their travel, and it also builds collaborative networking where hopefully they will get employment opportunities when they graduate. Lastly, but most importantly, they have to be interested in working in a rural or a medically served area or a primary care area. I'm going to point out that it is not required. So I tell the students right up front, we would love it if you would go work in rural and underserved counties in your area, but you don't have to. If the students do go work in those areas, for 2 years afterwards, HRSA will pay them an additional $10,000 per year just because they're setting up practice in a rural area. If they go to an urban area, they're not eligible for that additional funding, but it certainly is an attraction. So we use the Rural Hub, the Rural Health Information Hub, to determine students' rural status. So this student was from Fremont, New York. We have them enter in their address. And then, of course, as you know, we run a report. So this student's rural urban commuting area code was an 8. Describing as a small town with high commuting. So this met our criteria. The rural urban continuum code for this student was a 4. So this student was determined to be eligible, and they were in Sullivan County. So that's how we determine their rural eligibility. Students are fully funded for 2 years. We pay all their tuition. They get a Dell laptop. They get clinical supplies. We pay all their books. They get a $5,000 stipend to cover their travel to their rural site. They're given extra support in some basic coursework. And I think this is important. We provide them with professional membership to the New York State Nurse Practitioner Association, the Rural Nurse Organization, which is a national organization of rural nurses, and the New York State Association of Rural Health, because we want them to be socialized in the profession of rural nursing. And then lastly, we fund them to take the National Certification Review course. And so far, all of our students have become nationally certified on their first exam attempt. So within our telehealth course, we teach these core competencies within our course. So we look at what is patient safety, how do we determine maintaining patient safety, and appropriate use of telehealth. We look at data collection using telehealth and assessment using telehealth, which is a big issue. We look at communication via telehealth. And here, one of our areas of research is helping the students maintain art of nursing and the science of telehealth, because we want them to be really adept at telehealth, but also helping them maintain that presence of nursing so that that patient feels cared for by a nurse. We go over ethical practices and legal requirements of telehealth. We talk about expanding technology using telehealth, like the inception of artificial intelligence and how that's exploding, remote monitoring, which we've heard about during the conference, and then access and equity to telehealth. One of their final projects is to create a project using telehealth. And some of the projects that have come out of here are pretty amazing. So we hope that we are creating the next generation of lifelong learners. It's a 3-credit course. It's asynchronous, so they do it from home. They do come in and use the computer lab, and we talk about principles of diversity of care, looking at telehealth structures, legal issues for both providers and patients. They practice in our simulation lab best practices for conducting that telehealth visit. We want them to feel comfortable, how do you feel comfortable turning the machine on, speaking with a patient, but also having somebody help you monitor that visit. We go over telehealth triage concepts. We talk about the operational end, the financial end, and quality improvement processes. And then how do we coordinate into professional care using telehealth? The last goal of our grant was to create the Rural Telehealth Educational Consortium. This is 33 different healthcare organizations in rural central New York. With the help of our collaborative partners, we've developed a 45-hour micro-credential course that was born out of this grant. We want to increase the number of skilled healthcare professionals that use telehealth and strengthen the capacity for telehealth. So we partner with national and regional stakeholders, including HRSA, and we generate ideas in telehealth. So we come together 4 times a year to really do a deep dive at what are the challenges that our healthcare organizations are experiencing. What are some of the barriers? But more importantly, what accomplishments, what are you doing to promote telehealth? And we share those experiences, hopefully, among each other so that we can continue to promote and advance telehealth in New York State. In terms of our employment characteristics of our awardees. So again, it's small, right? But you can see that we're increasing in capacity. So the dark green shaded area is where I want you to take a look. Of our graduates, our last class, we've had 30 of our students, 30 individuals have gone into a rural population of practice. 29 of them go into primary care. This is not mutually exclusive, so they may do primary care they may do rural that has primary care in it, or they may just be in a primary care setting. And then, of course, we will always have a small number of students who go into an urban setting or a specialty setting, which I said is allowable. So some lessons learned. Collaboration is key with community stakeholders, both so that we can maintain those clinical placements that we spoke about, but also make sure that we keep employment opportunities up for our alumni and more external funding. We learned that we have to acknowledge and incorporate those informal networks so that we can tap into those insider groups of people in the rural communities. We have to cast a wide net. You know, we do not practice in isolation. Our students are currently taught interprofessionally, so their core courses are taught with pharmacy students, social work students, and medical students. So we want them to be interprofessional providers. We have to be prepared for flexibility in student didactic and clinical needs. So an example of this is maybe a student was placed in a rural setting that didn't do enough pediatric care. We had to be ready to pull that student out of the setting and put them in a different rural setting that had pediatric care so that they could get that skills. Women's health is another one. They might be in a women's health setting that rarely does women's health. So we give them an alternative experience somewhere else to give them the women's health experience that they need. We know, as probably a lot of you here know, implementing telehealth takes time and education. Back in 2015, we purchased a lot of telehealth equipment. We couldn't give it away to rural partners no matter what we did. So we had to really work on how do we incorporate that and make telehealth be socially acceptable. Again, thank you to COVID, that moved forward. Our next goal is incorporating resiliency into our students and our workforce, because these nurses that we are preparing to go into rural areas have to become resilient. We know that nursing took a huge hit with COVID. Yes, we were known as the heroes, but a lot of nurses left nursing practice. So we want to incorporate resiliency so that we really have students that are not only prepared for rural, but also are resilient. So those are my references. I will stop sharing now, and I'll open it up to the audience for any questions or comments that I might be able to answer. And thank you again for this opportunity.
Thank you so much. That was fascinating and inspiring. I have one private message in the chat that I did want to share, just saying that this was so fantastic. This commenter was born and raised rural, and they're fascinated by this, and it is spot on, but not something we teach our new providers and nurses oftentimes. Therefore, they do experience a bit of culture shock.
Absolutely.
I'm also going to allow everyone to unmute themselves if they do want to unmute and have any questions that they don't want to write in the chat or have any comments to share, now you should be able to unmute if you do want to.
So not seeing any questions, I'll open it up to comments. I know that workforce recruitment is a challenge.
Dr. Rouhana, your audio is cutting out a bit. We didn't catch that last part.
I was just asking the audience if anybody had any success with recruitment of rural workforce recruitment. I know we are always looking for partners to expand on supporting educational initiatives for our rural partners. We currently have a pod of students that are up in Plattsburgh. That seemed to be a real area of need, and the providers were very, very inviting of our students. So that's worked out really well for us in that area.
There is one question in the chat, and while I read that, also Dr. Rouhana, if you're willing to put your email in the chat box, just if anyone has any follow-up that they want to email you about, that would be great. But there are two questions now. So the first one is, are there any state policy changes you would like to see to improve these things?
One area that is currently worked on by the state is providing tax incentive for clinical preceptors to precept students. So in medicine, many times there's where doctor is
You're cutting out again a little bit.
can you hear me? In medicine, we have some general medical education funding. So when a physician precepts a student, they will get payment for that. We don't have that in advanced practice nursing. So there is some legislation right now in New York State so that preceptors can get a $5,000 tax credit if they're precepting a student.
Thank you. There's another question. Have there been collaborations with other NP programs around the New York, PA, and Connecticut areas that work in other rural communities?
We haven't partnered with anybody yet. Our grant is a federal grant. I believe about 50 awards are made every 4 years. And I think that there's one other university up towards Buffalo that may have also received a new award. But we haven't formally partnered. Who we have partnered with, though, is healthcare organizations. So we are looking now in regards of, let's not change rural healthcare one student at a time, but let's change rural healthcare one healthcare organization at a time. So we work with Garnet Health. We work specifically funding employees from their organization. We work with Guthrie Healthcare System, which is on the northern border of Pennsylvania. And Plattsburgh University. So we tend to work with schools of nursing and healthcare organizations to partner with them to get students that meet eligibility, but also make sure that we have employment opportunities for our alumni after graduation.
Thank you. There's not any more questions in the chat. There is a comment. Amazing presentation. As a recent MPH graduate, the experiences that you provide to help advance rural care is amazing. They went into college in an urban area, and they did try to promote the issues and provide insight to fellow graduate students. And I echo that as an MPH grad. I feel like health disparity courses really do focus more on the urban side of things, and seeing more curriculum and opportunities to learn about rural health is so important.
Absolutely.
So Dr. Rouhana did place her email in the chat, just so everyone sees that. I'll give it one more minute if there are any other questions or comments that people want to share. As a reminder, this is being recorded, and when it is archived on our website and our YouTube page, we will send out a notice, and feel free to share the recording with your colleagues. We would love that. And we want to thank Dr. Rouhana again for joining us for our conference. This was an amazing presentation. Oh, I actually do see one question just came in. While the rates of cancer are similar across urban and rural areas, rural residents typically have poor outcomes. Has there been any initiative to increase cancer screening services?
You know, there are some, the Department of Health has had some out there that have been translated into major cancer screenings, primarily with women health, so breast and cervical cancer screenings, and those are usually offered free of services. So healthcare providers can offer these services, and the women can stop in to an agency with their card that they're provided through this program and just get a clinical breast exam, a mammogram, and cervical cancer screening. I am a nurse midwife and a nurse practitioner, and in full disclosure, my area is women's health. So that's the only one that I know of. But good, a very good point. The last thing I want to say is my research that I did as a doctoral student looked at cervical cancer rates across New York State, and the highest cervical cancer rates were in the northern area that I showed on the map and the Delaware County area. That was 10 years ago. And I looked at vaccine attitudes and rural parents' willingness to vaccinate their son. And I would just love to share that story with somebody if they're interested. But I'm really excited to say that the two variables that impacted willingness to use Gardasil was if my friends and family thought I should vaccinate my son, which is exactly what the literature tells us. And if my doctor says I should vaccinate. So it's important as us as healthcare providers to be ready for that. And yay, for the first time in 10 years, because of HPV vaccines, we are finally starting to see a decrease in cervical cancer among the young women who received Gardasil as children. So sorry for that soapbox. I just had to mention that since we were talking about cancer.
That is awesome. Thank you for sharing. I do not see anything else coming through in the chat. So again, thank you so much to all the participants for joining.
Thank you. It was a delight. Thank you.
Thank you. And we hope to see everyone at our next session at 11. We're going to have our award ceremony for our Rural Health Champions and our Telehealth Innovator Award winners. So hope to see you there. Thanks so much.